and welcome to episode 5 of CMTV. I'm Aubrey going, and today I'm joined with a longtime friend, collaborator, and colleague. Many of you will know him, James Waslaski. Hi, James. How are you doing?
Good to see you, Aubrey. Glad to be
Great.
here.
Great to see you, James. You and I go back a long, long way. I think we must be coming up on nearly 20 years at this stage since we started collaborating with your seminars over here in Ireland. I can't even remember exactly what year it is. That's how far back it is, Jim.
Yeah, it was a good 20 years ago, though. It was great.
Yeah, and it's really interesting to see how things have developed over that time. I know, particularly around the pandemic, both of us, along with a lot of people in the industry, really had to pivot and get used to doing a lot more stuff online like this. And we get a lot more familiar with chatting to people, demonstrating stuff. And today, I think this is going to serve us really well because this is really what I want to talk about today is covering the kind of topics, obviously not going into as much detail as we're going to go into in our seminar, but when you're over with me in November, we're going to be doing a seminar here in Ireland, in Dublin. And we're going to be doing 3 days. It's from the second, it's on the 2nd, the 3rd, and the 4th of November. So it's actually a Saturday, Sunday, Monday, slightly
Yeah.
different to the last one we did. And I'm looking forward to it. I think it's going to be great fun. We had a great time last time. Not only did we enjoy ourselves teaching, but I think the participants, the feedback we got afterwards was phenomenal. People really had a great time. But this time we're obviously covering different body parts. So, Jim, you're going to be covering the knee.
Yeah, Aubrey, I'm going to be getting into kinetic chain knee because, as we all know, probably 90% of knee pain comes from the hip and the foot. So we're going to be looking a lot at foot stuff like subtalar joint. I'm just going to bring a few models in here for demos. We're looking at subtalar joint. We're looking at long lock ligaments of the metatarsals. We're going to be looking at fibular glide and a lot of these things, pronation, supination that ascends into the knee. And we're also going to be looking a lot at the pelvis because without functional rotation of the iliums and a functional sacral pump and level sacral base, that you can't really treat knee pain. I was teaching this at a chiropractic conference, and we had 200 chiropractors, and 30 of them had knee pain. We did 3 things at the hip, no, 5 things at the hip, 1 at the knee, and 1 at the ankle. And we got the iliums rotating, we got the scar tissue released, we got the hip flexors released, got the glutes activated, and then we corrected tibial torsion, which we're going to do before we treat any of the other 13 things of the knee. And then we looked at the subtalar joint and fibular glide, and I got to be able to do that in 5 minutes. Those 5 things were done, and they got off in 98% of them didn't have knee pain. So when we add in all the other stuff we're going to be doing at the workshop and feeding off each other with that mastermind opportunity, it's just going to be brilliant. It's going to be a great time.
I'm just thinking when you're saying that, the question probably sounded very limiting that you're going to be doing the knee. The title probably doesn't even do justice to what we're going to be doing because we kind of have it down that you're doing the knee and I'm doing the neck. But we can hear from that description, what I take from that is this is going to cover everything feeding into the knee. It's not just treatment of the knee. So the foot, the ankle, the knee itself, obviously, which is going to be kind of the prime focus, but going up into the back. I love the kind of list of things that you mentioned are going to be influenced, the kind of the ascending syndromes. Is there any of those that particularly stand out to you that you would think? I'm always interested because I know you were mentioning about having chiropractors in and having knee trouble. The two of us did a seminar in Westport a few years back, and I remember there was a guy who had knee trouble, and like that resolved really, really quickly. And it just kind of struck me, is there particular aspects of, I suppose, things that will be outgrowths or ascending syndromes coming from a perceived knee issue that have particularly struck you over the years? You know, either cases you found really challenging or cases that you get great results with, whatever that might be.
Well, one of my most challenging cases was in Kuwait and Dubai. I had a really complicated shoulder patient. And I looked at the overpronated foot, which caused the tibial to rotate, which caused the femur to rotate, which caused adhesive capsulitis, which caused a sacral torsion. If you stop there, we're going to focus on that for the lower body just to cover knee. But if you take it into rotoscoliosis of the spine, thoracic kyphosis, the OA joint was locked into extension, occiput C1, C2 was compressed, spinal stenosis. So if we hadn't looked at the feet, we couldn't have treated the neck. And that feeds into the neurological stuff that we're going to do in the neck. Is a lot of that is still an ascending syndrome coming from the feet through the knee, through the spine, into the neck. So I think really the coolest part is looking again at this kinetic chain portion, how it'll enhance what we're both going to teach with knee and neck work.
Yeah. because it might seem on the surface almost that they're not connected, in terms of subject matter, if you think of the knee and the neck as separate regions within the body. But really, I suppose what we're going to be doing is, like you said, the whole point of a mastermind is to see how these things interconnect and integrate, and to both be able to zoom in on the specifics of the client's condition, but also back out and look at the big picture and see how one thing might be feeding into another. That's something that seemingly is occurring in a quite a distant part of the body is actually feeding into the issue that the person is having in the part of the body that you are treating. So I've always found that part of it fascinating. I love the thing about rotoscoliosis as well, because the two of us were involved in one of the Canadian conferences a couple of years ago. And one of the other instructors, shout out to Scott Dartnell as well. Scott runs a great show in Canada, along with a lot of other people. I know it's not a one man show, there's a lot of people that help out. But I was talking to Tara Nicole at one of those, and she's a really fantastic osteopath. And she actually identified something for me that I probably had overlooked, because when we hear the term scoliosis, we always think of the obvious, pronounced kind of like lateral curvatures of the spine. And she was saying, actually, with the rotoscoliosis, the kind of four-curve scoliosis, they tend to be very tight curves. And so it's not that obvious. I always thought I just had a flat back. And she's like, no, no, that's actually a very tight four-curve scoliosis. That things are just turning back and forth rather than this kind of the typical pattern that we think of with leaning side to side. I don't know, have you much insight into that, Jim? I know obviously you treat a lot of scoliotic uh, things that you'd see in your seminars and so on.
And I think Tara is quite brilliant. And one thing we add into that is if you have an iliosacral upslip,
Mhm.
that's going to appear to be an anatomical leg length discrepancy, but it's functional, or sacral torsion. We're covering all this, by the way, for the knee, sacral torsions. Then that actually enhances the actual scoliotic pattern. So I'm still studying with Nicole actually on hypermobility and scoliosis with Tara. And in fact, I just took a cranial osteopathic course, cranial for concussion, head injury, brain trauma. And it'd be nice to give some input on these cranial torsions that don't respond to cranial psychotherapy, that are quite intense. We learned a lot about it. So we're giving some input, of course, when we do the trapped nerves of the neck, because if your brain is in a straitjacket and the sphenoid bone is twisted and there's these 7 different coordination, like a Rubik's Cube, we learned how to basically take the brain out of a straitjacket so we can get better peripheral nerve response in the brain stem, spinal cord, and spinal nerve. So it'll be fun to just bring a few new pieces. I think I spent the last 3 weekends in workshops studying that stuff. It was a nice new addition to what we both do, actually.
I think that surprises a lot of people. Like, we have new students coming in, we have a new intake twice in the year. And always in the welcoming, I say to people, this is one of these few careers that will continue to challenge you to develop and to grow decades into your practice. And I think that surprises a lot of people, that people like yourself and myself, we do continue to study. We're always finding new pieces of information, little nuggets that kind of add to your overall understanding, see how that integrates into your practice. And I think that's the difference that helps us to get resolution quite quickly, but also treat those really complex cases, because that's really all I see in clinic these days. I take clients occasionally by referral. So people will send in the really complex cases, the ones they can't get anywhere with. And it's one of the things that I oftentimes say when your name comes up in class. I'd say James is a master at particularly things like the kind of frozen shoulder. But what is always really impressive is the speed with which you affect change. Now, I know a lot of that, we've talked about this before, is down to really accurate interpretation of assessment, and how then you're going to continue. Really, like, assessment isn't a separate part of the whole consultation with your client, that it is a constant dance back and forth between treating, assessing. I know that you're as passionate about that as I am. Is there anything you could maybe go into about some of the assessments that are kind of your go-tos, or things that you think are going to be particularly relevant in this upcoming weekend?
Aubrey, one thing I think we've both brilliantly done is we don't present 3 or 4 or 5 techniques and expect that one of them is going to work. We both of us have really we haven't dummied down the information, but we've simplified. Okay, so now I do one assessment, one technique, a pause, reassess, then next assessment, next technique, a pause, reassess. So we're layering this what could be very complicated stuff onto a checklist. So it's assess, treat, check your work, assess, okay, reroute because that's not going to work. And I think that's so brilliant because, like, if we get into the knee alone, people use buzzwords like runner's knee, which simply means you injured your knee running, period. That's it, right? We don't know whether it's the ACL or the PCL or the MCL or the LCL or the, patella tracking or bursitis or fibular head compression or tibial torsion or meniscus injury. There's like 13 different things, but by doing one assessment, one technique, and doing it as a checklist, you could narrow it down to three that we could focus our time on. And I like that you and I both brilliantly take this what could appear complicated information. Then we just say, here's our checklist. These are the two or three little things. Now, if we treat those three little things and make it simple, then you're going to get quick and easy results, which is really kind of cool. We're both sort of branching into that very specific assessment, treatment, reassess, and then reroute kind of thing.
I always think of that as the unbroken chain to success. That if you can do each of those pieces, treatment becomes really very seamless and results follow very, very
Yeah,
quickly. But I think there's oftentimes a gap is somewhere in that chain for therapists, even experienced therapists,
yeah,
that for a lot of people I find they're generally pretty good at the consultation. They're able to use the information they got in consultation to inform what assessments they're going to do. But I
mhm,
think the first stumbling block for a lot of therapists is being able to interpret the results, that they know what tests should be applied in this area. But I think it's the interpretation of the results. Like you talk a lot about the different end fields and how you're not always going to do the same thing. A different response to a test indicates the application of a different approach or a different technique.
yeah,
That's that responsiveness that you're not making assumptions. You're not just throwing the kitchen sink of techniques at the particular client, that you're being able to interpret the results of the test you've just done and
mhm,
then apply a technique and then reevaluate and see, did that resolve it? Or, I oftentimes say clients are rarely so polite as to come in with just one thing. But oftentimes you can have multiple. I mean, you name several of the ligaments in the knee. And it frequently happens that, particularly if it's like traumatic or an old trauma, that they've injured more than one structure.
yeah,
So the tests can seem a little confusing if you do try that battery of tests approach because several things are testing positive.
yeah.
Whereas if you test one thing and treat it and retest and go, okay, well, now it's changed or it's improved or the location of symptoms has changed. Now that indicates assessing a different structure and we'll treat based on that.
And even as we go through this evaluation, you have to sequence things in the proper order because if you have a tibial torsion and you do a valgus stress test, you get a false positive articular ligamentous referral, which means it's not a ligament sprain, it's under torsion. So if you don't do certain things first, you get a lot of false positives. So then you start chasing pain, which we all know is not a good idea. So we really narrow it down to if we could sequence, like even when I did the cranial osteopathic, because I had a concussion when I was hit by the drunk driver in 220, it was like the Rubik's Cube. It's like this one can go this way, but this one has to side bend rotate. And for me, doing cranial psychotherapy never moved the cranial sutures like this does. And it was
Mhm.
like you're going, okay, the Rubik's Cube, if I don't do this, then the sphenoid bone can't root, and then that muscle test's weak. And so you have a way to narrow things down to, oh, it's a frontal bone lesion leading to weakness. So, like, there's so many cool things we can do, but what I love how we do it
Mm.
is my daughter even said with her autism and dyslexia, she goes, I love about what you and Aubrey do now. You do one assessment, one technique, you reassess, and then you give them a break to think about it. Then you do one more technique. And then the coolest thing we do is we look at the same thing from a different set of eyes, a different set of lenses, which is really cool. And then you'll see that P and F pec minor thing, and I'll see that humeral head decompression. Whatever we see, we combine. And I just love doing that. I loved when we did that in Canada and we did that last time in Ireland. People were like, "This is really different. This is awesome. We're getting 2 teachers at the same time, feeding off each other to take it to another level," which I really look forward to this.
Yeah, I always think we've great fun because I think the two of us, like you said, we have a very similar approach, but yet every set of eyes you put on a condition, each person is going to pick out something that maybe the other person is not seeing or are seeing from a different angle. That, even we say this with clients as well, that if a client is seeing a couple of therapists, particularly if it's a couple of different disciplines, each person bringing their own lens is helping to address a different aspect of that person's condition. And so, obviously, that's going to give a better chance of full resolution of that person's particular
Mhm.
condition. But I love the nerve stuff as well, and the idea that it can even start off just around the dura kind of being too tight, like you said, the straitjacket around the brain is a really nice way of putting it. That we can look at these kind of individual areas, things that seem complex, when we take it one step at a time and say, well, here's the list of places in which a nerve may be sensitized, compressed, irritated, and simplify it by going, well, here's step one, let's check that and treat the surrounding tissues. Then here's step two, and we'll do that, and step three. And I think people who've done a lot of study with myself or you are probably getting used to that approach, but that's not the standard. I know I've seen an awful lot of teachers where they'll do what a lot of, I think, common practice is they'll do a slew of techniques. They'll demonstrate 10 or 15 techniques and then go, now go do that, go practice. I don't know. Do you see that changing much in the States, Jim, or is that still kind of commonly how things are taught?
It's interesting that I teach, about 20 conferences a year. So I pop other classes and I'm still seeing a lot of techniques without any evaluation. I'm still seeing this. They're doing like 5 techniques and hoping that one of them addresses the condition. But the problem with that, Aubrey, is here's an example with my wife with a flat back and a herniated disc. If you have Fran pull her knees to her chest and flatten her back, she can't get off the table because you've just taken a flat back with a ruptured disc and made it worse. So the only problem I have with a bunch of techniques is many times you take one or two that make it worse. So meaning if you're just doing a series of techniques, we should always saying, does this feel better? Does this feel worse? And the ones that make it worse, we shouldn't do those. But if we could proceed that with assessment, we would know, hey, this excessive lordotic curve compared to this flat back needs a different treatment. This rotoscoliosis with this leg length discrepancy needs a different treatment. So let's not try to do a shotgun approach of techniques because the likelihood is one of them is going to make the back worse or the shoulder worse or something worse. And once you create pain, you upregulate sympathetic stress. Once you upregulate sympathetic stress, you upregulate guarding, and then they can't relax and invite you back into the tissue. So it's really, I've learned a lot about assessing to know when to reroute, assessing know when to abort a technique, assessing know to that this technique, even though it works for 80% of the population, will make this patient worse. And that's the beauty of every technique starting and finishing with assessment.
And I'd oftentimes say that, there is no one assessment that gives you the complete picture. And so going back and reassessing and trying other assessments as well. Like I love when you're mentioning about, getting the pelvis out of a torsion pattern. That's one of my absolute passions because I think so many people will benefit from that particular treatment. That pelvic torsion, I mean, if you took 100 people in off the street, I would say 99 of them, maybe even 100 of them, are going to have some degree of pelvic torsion. And I think the classic example, because I would always say, ultimately, I think palpation is kind of the gold standard of assessment because healthy tissue shouldn't be sort of palpation. And if you were going on something like the position of bony landmarks, when you're getting a pelvis out of torsion, it can sometimes look like the condition is getting worse, the torsion is being more exaggerated. But if you go by palpation, the person's sensitivity, their pain is reducing with each application. So this is where you need to have a broad scope of what are the relevant assessments to do, and how might I then validate that with another assessment that you're not being thrown by just one assessment. I mean, the classic example, like you said with Fran, that if it's making her back pain worse, the other assessments don't really matter. You're making that client experience more pain.
Exactly.
So that knowing what is the important gauge in each technique, I think is going to really be helpful for people as well to build confidence that they know when they're going in the right direction. They know which assessment is going to give the, I'm not going to say the truest, but maybe the most relevant finding in a particular treatment in a particular body part. I would think pain reduction is the big one. I mean, that's what most
Yeah.
clients are coming for. They're not like, I want my pelvis to be level. They're like, I want my pain to go away. And we do that by leveling their pelvis.
Which is the really cool thing about the perception of the word deep tissue. So many of the people that come in think unless you get in there and make it hurt, it can't be deep tissue. But you and I both know when we offend the brain, we offend, by bending the tissues, we offend the brain protects. So I think one of the things I share too is one of the quotes of Ida Rolf, it's not how deep you go, it's how you go deep. And that's just not physically, that's energetically, that's emotionally, that's the guardedness, the need for position release, strain, counter strain, and all these things that calm down the nervous system so that you can be invited into the tissues. And I think that we think so much alike on that aspect that we're not ever just getting into that trigger point. You know, you're gauging tissue. And it's another reason I like feeding off you. And a lot of people go, well, I'll take your workshop. They'll go, did you really learn that Peck minor thing from Aubrey? I go, yeah. I'll give credit to the people that refine, update, develop, you know, and I think that's what's cool is when COVID hit and we all mastermind with leaders in our industry, I thought, what if we could do a seminar and it could be Eric Dalton and you and Tom Myers and myself and et cetera, et cetera, et cetera. But I think we're finally doing that, which is quite awesome that you're not going to just see your input on the neck, but I'll say, Aubrey, do you mind if I give a suggestion or input? What do you think of this? And I like that that's how we work with these 3 days. And when we did in Canada, you didn't get the feedback, but I had more people when I went back go, oh, you need to have Aubrey with you again. This was so cool when you both looked at the same condition. So it's going to be probably one of my funnest experiences to co-teach like that.
And I think the participants get so much out of it because you are getting two complementary but different takes
Yeah.
on how to do treatment. It's not that they're so different that you're going to say, "Oh God, how do I switch gears in my brain from one approach to another?" That
Mhm.
it's not that different, but it is a different lens. It's a different approach, but there is definitely going to be synergy. And I think the interesting thing about the idea of mastermind is this isn't saying that we are the masterminds. It is
Yeah.
the bringing together of myself and yourself in our teaching approach, but also the people in the room because we feed off them, they feed off our ideas. People will oftentimes approach things in a certain way. We'll see it in class and go, "Oh, that will work. That's a good way. Everybody want to take a look at this?" Or I always like when you get somebody in the room that doesn't respond the way everybody expects because it's such a great learning experience. It's a learning
Mhm.
experience for everybody, us included.
Yeah.
Definitely looking forward to that. And I think where we were talking about like the nerves part as well, like calming down the neurology, getting the tissues out of that kind of tensioned, torsioned kind of pattern is going to make a big difference. But also, I think I'm going to be talking a little bit about nerve glides in the upper extremity as well. So talking about we're going to do some what for most people is kind of unusual stuff. We're going to be doing some sideline work on scalenes. So guys who've taken classes with us before, they've oftentimes seen the supine version. We're going to do sideline and see how that gives us new options for movement during treatment, for really getting the fascia to floss a little bit more, get a little bit more mobility into the tissues, and of course, calm the nervous system and get those nerves gliding again. So that I think is going to be a particularly interesting part.
And I like the idea of freeing up nerves rather than for many years we used a term called multiple crush phenomenon.
Mhm.
And for me, I don't want the perception of the brain to think your nerve is crushed, you know, like a hammer and just boom, crushed. I want them to think it's maybe trapped in a femoral opening or pressed on by a bone spur or an osteophyte or some scar tissue, and that we can get in and kind of free that up because the general mindset, hey, I need surgery because I have neuropathy in my arm. And I like that you're focusing on the neck because
Mhm.
brainstem, spinal cord, spinal nerve. It's this thoracic inlet before it ever gets to the clavicle and pec minor is pretty critically important for any peripheral neuropathy. I think so, and I like the fact that we're not saying they're crushed; they're simply trapped in different areas of the body, and we free
Mhm.
them up and loss and tension them. So it's going to be really fun review of a lot of a lot of old and a lot of new and update information.
Oh yeah, like I tend to use the term tethered a lot when it comes to nerves, particularly when you go to do nerve glides because you're trying to untether. That
Exactly.
I think there's a greater subtlety than the previous kind of descriptors might have implied. That rather than thinking of crush phenomenon, people think of like, catching your fingers in a piece of machinery and they crush your fingers. They think about this really brutal, traumatic kind of thing. Whereas tethered, it sounds kind of softer, but yet you can still get quite significant symptoms because you can have sensitization of the nerve. I oftentimes think there's some reduction in axioplasmic flow. There's a buildup of metabolites, so this is contributing to sensitization as well. That it's about fluid dynamics, it's about fascia, as well as it being about the nerve itself and its properties of glide and reduce stretch compared to the other tissues. And I think that's an easier concept for people to get their head around, that you're just freeing up something that's a little stuck rather
Yeah.
than crushed. And
And
again, not that the old explanation was bad, but just that the terminology suggests something different.
yeah. The general public has a mindset of something different than what we meant by that. So I'm kind of trying to downplay the word crush and go into what you're talking about, tethered, compressed on by a bone, facet joint, scar tissue. And I think it's cool because when we clear all that up, the functional outcome is that you can treat distal nerve pain if you treat the proximal entrapments. And so it's going to be fun. It's going to be really a good time.
Yeah. One last topic I wanted to talk about, James, because I thought I was quite intrigued by this. We've talked about this in some of our previous episodes of CMTV. We do a seminar here called Therapeutic Tools, where we use vacuum cups, we use scraping tools, we use Cryoderm. Actually, I know you're sponsored by Cryoderm, and they're fantastic products. And we also use kinesio tape. So you were talking about cupping versus foam rolling for some conditions of the lower limb. So just curious to hear your take on it.
You met Brad Norris from Canada, from
Yeah,
Rock Tape. Brad Norris.
yeah.
Brad was just 2 days ago was in my 5-day intensive in New York, right? And he is got the, in my opinion, the best research on cupping and scraping and taping, right? So he comes and talks about fluid hydration and moving in. So he did a demo on cupping, and then he did a demo on taping to support everything I did during the 5-day. And it was a lot of a neuro change. It was a lot of reminding the brain how to feel safe, because the information coming in, it's going to hurt if I can give your brain a different sensory input. So I liked how he stuck with the PubMed, cupping as an antioxidant, anti-inflammatory, neuromodulator. So, but mostly tissue hydration things. And then the taping, he didn't call it supporting unstable joints. He called it neuro reset stuff. So it's intriguing to see the updated research about cupping and taping. And I believe all of those things can enhance the work we do with our hands. And Brad likewise said they don't replace what you and Aubrey do with your hands. They support neurologically the nervous system's feeling safer when the movement and the exercises are done after the treatment. So I think they're fantastic adjunctive therapy tools for what we do.
I even think the comparison is very interesting when we're comparing cupping to something like foam rolling, because we even say, like, with hands-on techniques, they're invaluable. On our therapeutic tools seminar, we do myofascial techniques as well. You do those first, and then you do your cupping, you do your scraping, and then you finish with taping. But the really unique thing about cupping in particular, like, I know there's lots of different styles of cupping, and we could talk about that in a little bit more depth, but most applications, you're pressing into the tissues, you're creating compressive force. Cupping is one of the few things that actually opens up space within the fascia because it's lifting tissue. And compared to something like foam rolling, I think foam rolling definitely has its benefits. It tends to be badly applied. You know, you see people resting their full weight on it, and it's a bit like the old approach to deep tissue. People think foam rolling should be, the more painful the better, the more intense the better, which is not the case at all. You're irritating the nervous system, you're causing guarding, you're creating tissue crush against bone, you're literally pinching muscles between the roller and the underlying bone, which I think is totally counterproductive, completely unnecessary. And when you look at I mean, foam rolling can be done well. It does have its benefits. I don't want to detract from it entirely. But cupping really is unique because if you can lift tissue and create fascial mobility rather than simply compressing and trying to create shear, which you generally can't do with a roller. You can do it with some specialized stuff. I mean, both of us know of Sue Hitzman's work, that there are ways of doing it, but that certainly is not what is commonly done with a roller. And I think the opportunity to create lift and motion with a cup, not only is it doing many things at the same time, it tends to be much more tolerable. There is still intensity. You have to be careful not to overdo it with the cups as well. But the that unique element of lift, I think, is just
And
phenomenal.
and that's the only way I treat IT bands is I release the muscles of the hip and do the cupping on the IT band for the lift sensation. And even rectus fem, you've got the femoral nerve that innervates between the iliacus and psoas along the medial fibers of rectus fem. And the lifting of that, we had somebody, one of Brad's friends from Canada, he said, I've had femoral nerve pain forever. And we just lifted and separated rectus fem and the layers from intermedius. And all of a sudden that femoral nerve was gone. He's had it for like 12 years. And that's the benefit of vacutherapy and lifting and separating of the tissue rather than your traditional sports massage pre-event that compresses all the quads downwards, which can trap the femoral nerve and reduce some quadricep function. So again, because that's feeding the knee, I'm going to be talking a bit about that too, because it's a difference in how I used to do pre and post event sports massage.
And it's just interesting to see how these things evolve. And even how, something like cupping has been around for millennia, but the approach, because the rationale, the understanding is changing, the application is changing, the intensity is coming down, we're getting greater results. And it's going back to the same thing, particularly with that femoral nerve, that if it is entrapped, if it's basically stuck within the surrounding fascial envelope, creating lift creates space, which creates opportunity for motion. And we can see how that's going to have a really profound effect on something that can just go on and on and on and continue to create symptoms for years.
Exactly.
Yeah. So you made an interesting point at the start there, James, before we started recording, where you were saying about, particularly for folks that are traveling to the seminar, you were saying that you were looking a little bit
Really
at flights.
fantastic, Aubrey, is I'm doing a retreat in Ireland and in Italy, and the prices dropped to both locations 50% or less than what it was a month or so ago. So right now, I just Googled from a lot of the US states to Dublin is $522 for people to fly there. Typically, it's $1,000 or more. You may have to make a connection through London Heathrow, but they've got a lot of backup flights if your flight's delayed. So for $522, in fact, I'm trying to change my flight right now because it was half of what I originally paid. So I'm working on that. And it's a really good time. If you can pre-book like this, and I guarantee you'll have a blast. I mean, I've been to Dublin or to Ireland 15 times, and every time I have a greater and greater experience because you Irish folk are pretty fun to hang out with, man.
And that early booking definitely recommended.
Sure.
Jim, anything else you want to chat about before we wrap up?
I think I'm good. I'm really looking forward to the collaboration, the friendships, the camaraderie. I think we got probably better feedback in this last seminar we did together than in most of my seminars because they just loved we both become a bit more humble. We both become a bit more hungry for new information. And I think that our industry as a whole is supporting each other's specialties. And I think the timing is right because the Baylor just did a study saying that massage is becoming forefront medicine. It, at some point will not be alternative and complementary medicine. And I think we're right on the cutting edge of that. And I just can't wait to come back in November and show the students that.
Sounds good. And we'll be sure to put a link to your website. It's orthomassage.net. Is that right?
www.orthomassage.net. Yep.
Perfect. So we'll put a link in the show notes and we'll put a link to the seminar. So I would encourage you guys to go on and book early and you won't regret it. These seminars really are fun. And like I said, the feedback, it really strikes me. I mean, at every seminar, people have a great time. But the feedback from the last seminar that we did here in September of 23 was just incredible. And I'm sure we'll see a lot of those same faces returning again this year. So, Jim, I think with that, we'll wrap it up. And I'll just say thanks very much for taking the time to talk to us today. Really interesting to see how the knee is not going to be treated as an isolated structure, but how we're going to look at kinetic chain patterns. I think that's going to be fascinating and folks are really going to enjoy it. And I can't wait to have you back over here. We might even get in a pint of Guinness while we're here.
Sounds good, Aubrey. Good to talk to you. You have a great day, buddy.
Great. Thanks very much, James.
Thank you.
Bye. And thank you all for joining us. Make sure you subscribe. We'll post links to, as I said, each of the things that we mentioned in the show notes. And as always, if you guys have questions, we do like to address these in our upcoming episodes of CMTV. So if there's particular questions around techniques, around body parts, around conditions, if you've got follow-up questions for James, we might be able to get a hold of him again before he's back over in November, and we'll address those questions for you. So please feel free to post questions, comments, and suggestions. Thanks for watching, and we'll see you again soon.